quite a bit to cover, so I'm just going to go ahead and get into it. My name is Hannah Addison. I'm a master's student at the Chicago School. I have two little boys. One is a preschooler, and the other, the baby has been home with me since he was born last July. So this presentation was kind of born out of my experience being a working parent, both in securing safe and affordable childcare for my older son, and also in working with a baby at home day to day. So that was kind of the brainchild behind this. And Dr. McCormick, you want to introduce yourself?
Sure. Thank you. I am Dr. Lindsay Brown McCormick. I'm an assistant professor here at the Chicago School in the Counselor Education Department. And you can see my credentials there on screen. But for the sake of this presentation, the important ones, I guess I'll say, are that I'm a certified EMDR therapist. I'm a certified perinatal mental health provider, and I am a certified lactation counselor, all of which we will discuss during this presentation.
Oops. Just some real quick learning objectives, what we're hoping you get out of this presentation. And quick table of contents, just what we're going to go over. So jumping right into it, common struggles of working parents. The transition to parenthood. In a recent Canadian study, 18 couples who are transitioning to parenthood were interviewed about the different struggles that they were facing. The primary struggles include balancing different roles, the roles of parent, partner, and individual, the loss of a sense of self, and decreasing time for themselves. Often parents mention that the baby took up all of their available resources, making the primary role that of the parent. When trying to find a fair balance in childcare, most couples found that the childcare reverts to gender stereotypes. One mother said, even if everybody wants to make things fair, the baby is still going to want its mommy. One father mentioned, I get the impression that women have the innate ability to hear babies crying better than men, so it's really hard for me to wake up the way she does. Even in lesbian couples, the bulk of childcare falls on the childbearing partner. Frequently, the mental burden of the transition to parenthood falls on the mother as well. One mother said, to tell him, call the doctor and make an appointment takes so much more energy than if I just pick up the phone and call the doctor myself. Things like managing the entire pregnancy, the child's development, the child's attachment style, household management, all often fall on the mother to manage. Another burden of the transition to parenthood is dealing with societal messages about parenting. There's a lot of conflicting advice from professionals and friends alike. To pressure to breastfeed, vaccine schedule, growth curve, sleep training, all have a variety of different social messages attached to them. Immigrants feel the pressure to conform to their home country's standards as well as their new country. One mother said, in France, they're really opposed to breastfeeding. My mother's really against breastfeeding and everything. Every time I call her, she's always trying to convince me to stop breastfeeding. So dealing with conflicting societal norms can be really challenging as well. Also, the idea that people have to be both a parent and more than a parent. One mother said that she feels like a woman has to be a little bit of everything at the same time. Continuing on, chief complaints by parents in the transition of parenthood are fatigue and exhaustion. Whoa. Psychological distress, high stress, too many new responsibilities, and a lack of social support. Having a baby means waking up often at night to feed it, and for mothers who breastfeed, that is often entirely on them to handle. People often suggest the mother pumps to allow other people to help feed the baby. But pumping is a time-consuming and sometimes uncomfortable or even painful process in and of itself. Also, in order to maintain supply, many mothers are told to wake up to pump several times a night anyway. So while this is an option, it may not solve the lack of sleep problem. Sleep deficits and cognitive function. In a study investigating sleep deficits and cognitive function in mothers, they found that frequent night wakings, less sleep overall, and a lack of consistency in sleep schedule all had a negative effect on cognitive function. Interestingly, stress was not found to have an effect in cognitive function. They also found that mothers who attempt to go to bed earlier in order to mitigate some of these sleep deprivation symptoms didn't actually have any improvement in their cognitive function because they were still being woken up and their sleep was interrupted throughout the night. So it was still not getting them that necessary REM sleep. So the advice, sleep when the baby sleeps, is not particularly helpful. It takes a village. We've all heard the phrase, it takes a village, and a lot of modern parents are wondering where their village is. Grandparents vary in the level of care they are able or willing to provide. Some grandparents are in poorer health or have fewer financial resources that they can contribute. 40% of grandparents live over 200 miles away from their furthest grandchildren and aren't in near enough proximity to offer frequent care. Many grandparents are still employed full-time as the age of retirement climbs up a little bit. And some adults have strained relationships with their parents, and it makes it uncomfortable for them to ask family for help. For grandparents who were involved on a regular basis, many of them found improvement in their cognitive function and overall enjoyment of life. But for those who were participating on more than a regular basis, such as sharing custody or taking over custody, they actually found a decline in cognitive, not development, but deficit, a cognitive deficit. So being involved, asking your parents for help and grandparents being more involved is a hit or miss resource right now. For paid childcare, it's challenging to find safe, affordable childcare. The United States, as we know, has no federal paid parental leave. There are childcare deserts throughout the US for ages 0 to 3, meaning there's only enough licensed childcare for 23% of infants and toddlers in the United States. Since there's no federal paid parental leave, many families don't have a choice. They have to go back to work, and they also have to find childcare. Sometimes a parent's full paycheck or more goes to childcare, and people may suggest that they quit to save money and spend more time with their kids, but sometimes that's not a practical option if their job is the one that offers benefits like insurance. They have to stay employed, or just because they want to still have a career. Additionally, these childcare deserts disproportionately affect people of color and low-income communities, contributing to the cycle of poverty. Work-life balance in parenting. A drawback that I want to mention before we get too far into it is that research on work-life balance in parenting is primarily centered on heterosexual career-oriented parents. So upper middle class parents that both want to focus on their careers. There's not a whole lot out there for people who are just struggling to get by. Fathers are assumed both in research and in the workplace to not need or want work-life balance policies, which marginalizes the fathers and assumes them to be less involved in their child's lives than mothers are. Marginalizing fathers' roles perpetuates the idea that men are the primary breadwinner and that women will be sacrificing their career growth. For both mothers and fathers, there's a fear that prioritizing their children means they will be perceived as being less committed to their job, which would lead to fewer opportunities for career growth. Since fathers are assumed to be less interested in childcare, most of the reduction of opportunities for career growth falls on the mothers. Anecdotally, I hear a lot that it makes sense that mothers are sacrificing their career growth since fathers are making more money to take care of the family anyway. It's a huge part of the problem. A lot of times these balances are not really consensual. Mothers are sacrificing their career, causing them to make less money, causing them to have an unequal balance in the role of providing financially for the family. That could be a whole presentation on its own, so I'll skip past that. Balancing home life and work leads parents to focus less on self-care, leading to burnout in the workplace and at home. Inflexibility of work schedule plus limited childcare options and varied child schedules is an additional challenge. Some pros of working from home while parenting. Increased flexibility, less commute time, increased parental engagement for mothers, but in the United States, that's not applicable to fathers. In cultures with an egalitarian parenting model, fathers also show an increase in engagement, but not in the United States. Some cons of working from home while parenting are blurred lines between work life and home life, reduces psychological well-being, primarily in mothers. Again, when both parents work from home, it reinforces gender stereotypes that mothers will be the ones to sacrifice their career in order to handle childcare while the father continues to work fairly undisturbed. That is right at 10 minutes. Okay. There you go, Dr. Byrne.
Thank you. So we're going to shift gears here a little bit, and we're going to talk about some mental health concerns and clinical interventions as they're applied to parents. And we're especially going to look at perinatal period. Thank you. So we're talking about perinatal mood and anxiety disorders. Hannah talked a lot about, that introductory transition into parenthood, whether that be with your first child, with multiple children that you already have, bringing a new infant into the picture. There's a lot of different transition that occurs from becoming a new parent to becoming one child to two children and so on. So let's talk about perinatal mental health care. I love talking about perinatal mental health care. Why use the word perinatal? Most people, when we talk about mental health conditions or concerns that go along with being a parent, most folks are familiar with the terms postpartum depression and postpartum anxiety. But there's a big shift in the perinatal mental health sphere to change that from postpartum to perinatal. And so perinatal encompasses that moment from that time that birthing person finds out that they are expecting to 1 year postpartum after birth. And so there are these specific mood and anxiety disorders that we associate with the perinatal period. Perinatal depression, which is different than the baby blues. That biggest difference being baby blues happen because of a shift that occurs, right? So when that woman, that birthing person is pregnant, there's all kinds of different hormones that are activated, that are surging to keep that fetus alive, keep that fetus going. And then once that individual gives birth and gives birth to the placenta, you have that dramatic shift in hormones. So the estrogen levels drop dramatically. Estrogen, and I can't think of all of the different hormones that play right now. But you're looking at a decrease in estrogen, a slight decrease in prolactin. We still use prolactin to create milk, to do human milk. But the baby blues occur because we have that hormonal shift. And the biggest difference, some of the biggest differences between the baby blues and perinatal depression are baby blues typically last about 2 weeks. after the birthing experience. And most folks who are experiencing the baby blues tend to still have a cheery disposition, whereas with depression and perinatal depression, we're looking at all of the similar and a lot of the similar symptoms that we see with major depressive disorder, but then that shift in the way of thinking. So, like when I say the shift in the way of thinking, what I mean is rather than that person feeling a sense of worthlessness or a sense of hopelessness about themselves, it shifts to, my baby deserves a better mother than me. Or my baby would be better off if I just weren't here. So there's definitely that shift with regards to the content in how that hopelessness, that sense of hopelessness and those feelings of worthlessness um, display themselves in perinatal depression. And then again, talking about postpartum anxiety, perinatal anxiety occurs all throughout pregnancy and postpartum. And when we're thinking about perinatal anxiety and perinatal obsessive compulsive disorder, it's really common, actually, the intrusive thoughts that occur with regards to, like, there's a lot of fears and concerns about, well, what if I touch something that has a contagion and I pass that contagion on to my baby and my baby gets ill or passes away because of that? Or a very, very common one is fear of falling down the stairs. So there's this fear of falling with the baby in your arms or while you're wearing the baby, and you causing injury due to that fall. There's injury that's caused to that infant. And especially with regards to obsessive compulsive disorder, perinatal obsessive compulsive disorder, folks will, as they do with obsessive compulsive disorder, traditional obsessive compulsive disorder, will find they won't engage in the behavior at all. So maybe you've got a parent who won't turn on the stove at all because they're afraid they're going to leave it on. Or you've got a parent who won't go down the stairs, won't because the fear of injuring that infant if there happens to be a fall, and so on. And then looking at post-traumatic stress disorder, we don't necessarily label post-traumatic stress disorder as perinatal post-traumatic stress disorder, but PTSD from things like a traumatic birthing experience or a traumatic birthing experience or an experience, for example, where you have maybe a caregiver or a healthcare worker who has a very invalidating experience, gives that individual a very invalidating experience. Even that can be considered traumatic. And then lastly, perinatal psychosis. And so what we mean by perinatal psychosis is a psychotic event that occurs during that perinatal period. And we'll talk a little bit more specifically about some of that here in the next little bit. You can go to the next slide. Thank you. So there are several risk factors that are associated with perinatal mood and anxiety disorders. And so throughout some of these slides, you'll see PPD for postpartum depression. Unfortunately, a lot of the research that still exists and is still out there, and a lot of the research that we still use and count as relevant, focuses on postpartum depression and postpartum anxiety specifically, rather than that entire perinatal period. So in terms of risk factors, things like having a prior history of depression and anxiety is a potential risk factor. multiple children, having a high risk pregnancy. So that can mean a lot of different things. An emergency C-section, having a hospitalization, and so on. Or maybe you're having a fetus that prior to birth, is going to be medically fragile. Having complications, poor social support, being from that low socioeconomic status, and then things like poor sleep hygiene, and what we term or deem a poor diet, or a diet that might be lacking in some of those nutritional needs that we have. All of these things can be considered risk factors for perinatal mood and anxiety disorders. Next slide, please. So there is a considerable amount of evidence that shows that at least postpartum depression specifically is much more likely to occur in BIPOC folks. But even though those numbers are high, folks who are in BIPOC communities are much less likely to seek any sort of support or treatment for any of their perinatal mental health concerns. I think sometimes, especially with these numbers, recently here, the policy for maternal mental health released, I think it was last week actually. They had the release of state to state care, how states were doing with regards to perinatal mental health care, accessibility to perinatal mental health care, and almost every state, there's only a handful of states that are in the US that have enough access, have enough folks who are certified, and have enough providers to give folks the means and the accessibility for any sort of specialized perinatal mental health treatment. One thing that actually isn't mentioned in this particular PowerPoint that you might notice is talking about LGBTQ plus folks and LGBTQ plus families. And again, there's not a lot of research out there that's been done on it. There are organizations like Postpartum Support International that are doing some great work to try to bring some accessibility to LGBTQ plus families, especially with regards to perinatal mental health. But unfortunately, there's not a lot of stuff out there. Next slide. Thank you. So the Edinburgh Postnatal Depression Scale, the EPDS, is typically the go-to assessment tool when we're looking at least depression. So the EPDS is a 10-question scale. It looks at depressive symptoms with regards to things that individual has experienced in the last week. So typically it's not used on its own. When I use it, I don't use it on its own. I typically pair it with a few different assessments, a GAD-7, a PHQ-9. But if someone comes to me and they're seeking services and they describe any type, if they've, in that postpartum period, a EPDS is my go-to to sort of see and assess where that individual is at with regards to any sort of postpartum depressive symptoms that they might be having. Unfortunately, it doesn't screen for things like anxiety, personality disorders, or any sorts of phobias. But again, it at least can give you an idea of if that client that you're seeing is experiencing any sort of depression related to the postpartum period. Next slide, please. Thank you. So Xarelto is a newer medication that is used for severe perinatal depression and psychosis. It's found to be very effective, and it's not a quote unquote traditional medication like you would go to a psychiatrist and receive a script for the medication and go home, get it filled at the pharmacy and take it. It is an intravenous medication that is given in a very specific setting, and it is administered over a course of 60 hours. And while it is being administered, the individual who's receiving the medication has to be closely monitored because of the side effects, and also has to be closely monitored while they're interacting with their child or children to ensure its effectiveness. And I've got there specifically know who and where in your state administers Xarelto because there aren't a lot of places that provide this medication. So I'll give you a prime example here. I am in Southeast Ohio, and I provide teletherapy to multiple different states, but they're all Appalachian states. And here within the last few months, in Southern West Virginia, specifically it was Greenbrier County, West Virginia. You might have heard the name Greenbrier before. Greenbrier County is famous for and known for the Greenbrier Hotel in White Sulphur Springs. But outside of White Sulphur Springs, Greenbrier County is incredibly poor. And so in terms of means and accessibility, in Greenbrier County in the last few months, there was an infanticide case that occurred due to severe perinatal depression and postpartum psychosis. And so a medication like Xarelto, which would have helped this individual significantly, if you're in Greenbrier County, West Virginia, the closest place to get that medication administered to you is Pittsburgh, Pennsylvania, which is almost 4 hours away. And if you're in a situation where it's hard to get gas money, let alone don't have reliable means or transportation to get to a place like Pittsburgh, it's not really a viable option for folks. In my home state of Kentucky, there's one place that administers Xarelto, and where I'm from, it takes 5.5 hours to get to that site because it's in Western Kentucky. So the reason why I've got know and who, where in your state administers Xarelto is for that very reason. Know where Xarelto is administered, especially if you're going to start doing some of this work, or if you anticipate doing some of this work, because you may need to refer a client to that area, to that place in the future. Next slide, please. So when we're looking at therapy and we're looking at therapy interventions for perinatal mood and anxiety disorders, typically the go-to is psychotherapy and antidepressant medication. Most of the time, there's a significant amount of women and birthing persons who decide against any sort of medication, especially if they are breastfeeding. That doesn't mean that they can't. There are lots of medications that have shown to be safe for pregnancy and breastfeeding. But the fact remains that there are a lot of folks who opt out from medication. A lot of there are the therapeutic interventions that are listed here on the slide have been therapeutic interventions that have been endorsed by Postpartum Support International. And Postpartum Support International are the people, they are the folks who offer the perinatal mental health provider specialty. So you're looking at things like cognitive behavioral therapy, interpersonal psychotherapy, which is one that I use very frequently, things like behavioral activation, brief psychodynamic therapy, and then so in or EMDR, eye movement desensitization or reprocessing therapy. In the EMDR space, there is a lot of question about whether or not you should perform EMDR therapy sessions with someone who is pregnant. And I can say, as a certified therapist and a consultant in training through MDRIA, that it is okay to administer EMDR therapy to someone who is pregnant. A lot of the concern for that comes from the stress hormone cortisol, because we know that cortisol has an impact on fetal development. And I can tell you, I've heard other consultants, approved consultants, talk about this frequently and often, that more often than not, the benefits that somebody is going to have from EMDR therapy and those sessions are going to significantly outweigh any sort of impact that the cortisol exposure from those therapy sessions are going to have on that developing fetus. Next slide, please. So some important psychotherapy considerations. These are things that if you are more of a generalist and maybe don't necessarily specialize in perinatal mental health, or find yourself in session with a pregnant person or someone who has given birth or had a spouse who's given birth recently, some things you might consider when working with that individual. It's important that we approach conversations with empathy and understanding, which sounds kind of basic, especially if you're thinking about core counseling skills. But the reality of that is if you happen to be an individual who has some friends who are parents, or you're a parent yourself and you've ever been in one of those quote unquote Facebook bump groups, people like to have a lot of opinions about how other people parent. And so that's why I think it's important to approach these conversations with empathy and understanding, because it's not our role as counselors or clinicians to tell clients how they should parent, if they should sleep train or not sleep train, and so on. So making sure that you're honoring and respecting those clients' choices are really important. Sometimes the only option is going to be babies in arms. And I think that when you're working with, especially a new mother, if you have a new mother who's experiencing anxiety, especially anxiety related to separation from that infant, doing something like arranging childcare for a therapy session is going to probably cause a lot more anxiety than needs to be. So it's important to respect that babies in arms might be the only option, rather than to create pressure around trying to arrange some type of childcare. It's important to screen for traumatic stress because traumatic birthing experiences, invalidating experiences from things like hospital staff and so on, can lead to post-traumatic stress disorder. And I think, too, one of the things that we don't always consider is that someone who has a traumatic birthing experience might be getting a lot of invalidating feedback from people in their inner circle, right? And I think that's especially can be especially important if, say that individual had a traumatic birthing experience, they ended up in an emergency C-section, they brought their baby home. They, went through the traditional 3-4 day stay, and they came home, their baby's safe and healthy. And so they might be experiencing some traumatic stress around that birthing experience, but all of the people around them are saying things like, well, but at least you're okay now, or you got to bring the baby home, or the baby's okay. That's all that matters. That's all that matters. How invalidating that is to someone who's been through that experience, to have that echoed to them. So make sure you screen for traumatic stress. In terms of risk assessments, sometimes an inpatient hospitalization might not be the best solution. As Aiden talked about in the risk assessment presentation, we don't always have to send somebody to the hospital. And if you have an individual who might be struggling with some passive suicidal ideation, but don't necessarily have any means, intent, plan, have protective factors in place, an inpatient hospitalization stay, again, could lead to anxiety from being separated from the baby. If they choose to breastfeed, could cause some significant risk factors there as well. So it's important to consider that hospitalization isn't always the best option. However, if the symptomology requires an inpatient stay, we need to make sure that we do the proper risk assessment to screen for that. And lastly, if you don't feel equipped, refer to a perinatal mental health specialist, or get trained, or take some trainings on perinatal mental health care. I think that's super important. Next slide, please. So shifting gears into talking a little bit about advocacy and advocacy work. It's important that we talk about supporting breastfeeding families and breastfeeding parents, especially if we're going to talk about perinatal mental health care. And it might not seem like there's much of a link here, but in all honesty, there is, for a few different reasons. And so these numbers here show the current rates of percentages of infants who were breastfed ever. And these rates are from 2019. They're from the Center for Disease Control. And so within the CDC, we have the Healthy People Project. And so the 2030 breastfeeding objectives for the Healthy People Project are to increase our proportion of infants who are breastfed exclusively from 6 months of age, from 24.9% to 42.4%, and then increase the proportion of infants who are breastfed at 1 year from 35.9% at baseline to 54.1%. Now, that sounds and seems, even as a lactation care provider, to me, that feels like a lofty goal. And because like breastfeeding is important, and also there's like all of these other factors that go into that, which we're going to talk about on the next slide. So Well, the reason why I feel like, just in general, this seems like a lofty goal is because we have so many folks, so many mothers and birthing persons who choose to breastfeed and chest feed, but they don't get to the point that they intend to. And this has a significant impact on their mental health. Um, Hannah talked previously about that mom guilt cycle. And typically, because we have a lot of these campaigns and folks, maybe folks at the hospital, folks in our personal lives who are creating a lot of pressure to breastfeed, when we don't make it to those breastfeeding goals that we aspire to, that has a detriment on our mental health. And also, there's these things like infant weight and nutrition, having unsupportive work policies, having the lack of parental leave if you happen to be at a work site or work for an employer that doesn't offer any sort of parental leave, and so on. All of these things are contributing factors that keep mothers and birthing persons from meeting their desired goal to breastfeed. Next slide, please. So to talk a little bit more, again, switching gears here to talk about advocacy and resources. There are two particular acts, laws, that are in place that provide protection for nursing mothers and folks who are chest feeding. And so those are the Break Time for Nursing Mothers Law, which was passed in 2010, and requires folks who fall under the federal or the Fair Labor Standards Act. It requires the FSLA employers to provide break times for women to express milk in a functional space that is not a bathroom each time they need to express. Now, when Hannah and I were discussing this presentation and talking about some of the things that we wanted to discuss, one of the things that we talked about was the fact that we know so many folks who are like pumping in supply closets, which isn't the most glamorous thing, but is the reality. It's not a bathroom, but it's a provided space where that individual is able to express milk. And then the Pump Act, which was passed, took effect earlier this year. The Pump Act expands coverage to include teachers, nurses, farm workers, and a lot of other folks who weren't covered in the Break Time for Nursing Mothers Act. But the goal, the essentials to know about these two laws is that employers are required to provide a private functional space that isn't a bathroom, and then they're required to provide reasonable break times to express milk while that individual is working. More often than not, those times aren't necessarily paid. Next slide, please. Yeah, so moving into some more advocacy resources. I've mentioned Postpartum Support International already. PSI, there's the Policy Center for Maternal Mental Health, which has been formerly known as 2020 Mom. And then there's the Maternal Mental Health Leadership Alliance, and the MMHLA is doing a lot of public policy and advocacy work with regards to getting increased funding for the maternal mental health hotline and so on. And there's a lot of things that are happening behind the scenes on the public policy level and the public health level with regards to protections and increased advocacy and awareness for perinatal mood and anxiety disorders. Next slide. So quickly about Postpartum Support International. PSI does a lot of really great work with regards to bringing advocacy and awareness to perinatal mental health. So they have a helpline they call a warm line that can be accessed via call or text. It's offered in English and in Spanish. They have a provider directory that can be found at psidirectory.com. As I mentioned previously, they're the folks who offer the certification in perinatal mental health care. They're the folks that I am certified in perinatal mental health care through. And it's open to lots of medical professionals, psychotherapists, lactation care providers, and doulas. They also do things like the Mind the Gap series, which is a national collaborative to provide training on perinatal mood and anxiety disorders with other national organizations like March of Dimes. And then their outreach that they do every year is what is known as Climb Out of the Darkness or the Climb. And it's a 5K that is done in various states, various chapters and states engage in climbs every year as a fundraiser for PSI, for maternal mental or perinatal mental health research. And more recently, what I see we as the Postpartum Support International Kentucky chapter, which I'm a member of, we are using funds from ARCline to offer scholarships to folks who are interested in the intensive, the 2-day intensive Postpartum Support International perinatal mental health training. Okay, next slide.
All right, so there were just a couple other resources that I wanted to share with y'all for clients. The organization Paid Leave for All is an umbrella organization that works with a bunch of local organizations to advocate for federal paid parental leave. And something from their website that I thought was really amazing was, in a bad way, is 1 in 4 mothers return to work within 2 weeks of their child being born. And then 1 in 5 older adults retire early to care for an ill family member. So it's not just advocating for paid parental leave, but also disability leave as well. State licensing regulations for finding quality childcare. I never even thought to look this up when I was looking for my son's daycare, but you can search licensed childcare facilities in your area and see how long they've been licensed, how if they have any flags on their license, when they're up for renewal. So that's a great resource for parents who need to start looking for safe childcare. State workforce agencies resources for continuing education and childcare subsidies. These are super competitive, so they're not a first line, I would think, but worth knowing about because, of course, some people do get the subsidies. So for some populations, some low-income populations, I'm in the state of Texas, and Texas offers continuing education subsidies. And if you are accepted into this continuing ed program, they provide subsidies for childcare in a licensed childcare facility. Dr. McCormick mentioned the maternal mental health hotline. I put the number here for y'all. And they also, I thought was really neat, they have interpreters for other languages in addition to English and Spanish. So I think they had like 60 different interpreter languages available for interpreters. And then a different one that I really wanted to plug just because I loved it so much and found it so helpful for me personally was the book How to Keep House While Drowning. Casey Davis is an LPC, and it's not a cleaning book. It's very, very, very short. It's teeny tiny, written for people who don't have a lot of time or a lot of attention span, and it's really about reframing your approach to care tasks, reframing chores to care tasks, and how your environment serves you, not you serving your environment. So if you have any clients who are struggling with guilt of not being able to juggle it all, it's a great resource for kind of breaking down that guilt and allowing yourself to think outside of the box, think about ways to get tasks done that maybe aren't the right way of doing it, accepting help, hiring out help, not needing to deserve to hire a cleaning service or something. So I found it very helpful, very straightforward, to the point, not at all difficult for someone to consume when they already have very limited time. And now we have a pop quiz real quick for you. True or false, LGBTQ plus couples do not struggle with gender stereotyped division of labor in parenting. What do we think? Right. False. True or false, baby blues and postpartum depression are not the same thing. Correct. True. Which is not associated with a higher risk of perinatal mental, I forgot what the acronym stands for. Anxiety and depression, mood disorders. Anywho, high risk pregnancy, low income, baby gender, teen, mother. Baby gender is correct. Which of the following is a factor in how long a mother breastfeeds? Unsupportive work policies, cultural norms, issues with lactation and latching. All of the above. Thank you, Elena. Dara. All right, so now we have 8 minutes for questions. So if anyone wants to come off of mute or put it in the chat, we got plenty of time for you. Aiden put in the chat, knowing the availability of emergency childcare in your area for parents in crisis is helpful. Oh, that's a great point. For example, in Iowa, there was an organization of licensed foster care homes who could come take care of children when parents needed to go into crisis beds or the hospital. It was purely childcare. No rights were taken away. DHS didn't get involved. It was just a resource to help. It was such a relief when a parent was already in crisis. That is great. I didn't know about that. I love that.
That's amazing.
And I think that the slides are also going to be posted after the conference ends, as well as the recording will be posted to YouTube, I think. So I definitely encourage everyone to look at some of the resources on our reference list to read more in detail. I know we were talking really fast, giving just an overview.
Any questions?
Looks like we were pretty comprehensive.
I hope so.
Yeah, so if anyone has anything, we'll hang out for a bit, or I certainly can. I won't speak for Dr. McCormick,
Oh, yeah, I'll absolutely hang out.
but yeah. Y'all are free to go. Thanks for coming.
Thank you. Thank you for your
Thank
attendance.
you.